Yeah. So I welcome you all. Khammagani, welcome to the land of tapestry of sand dunes and a place known for great hospitality and cuisine. So this will be our IC, the most cost-effective eye hospital model to provide the best clinical services with supreme results. So we have eminent speakers, Professor Manisha Rathi, and she will be speaking on role of counseling in the modern era. And I request Dr. Santanas Gopal, our ex-president AIOC, to kindly come on the dais. Dr. Rajendra Prasad sir, the Terminator, the great innovator and the greatest of all, GO80, greatest of all time. Dr. Jagdeep M. Kakadia to kindly come on the dais. Dr. Rakesh Shakya, the fastest surgeon in the world, who finishes FACO. Yes, rocket surgeon, who finishes FACO and SICS within 63 seconds. Dr. Rakesh Shakya, he is here? Okay. So I welcome you all. So without any further delay, because we are already delayed by 5 minutes, so I request Dr. Jagdeep M. Kakadia sir, and he will be speaking on most cost-effective microscope and video recording system to grow and learn.
Thank you, Dr. Moria. Thank you for including my talk in this session. 11:30. Big load key.
Yes, sir, please. This live is not coming. Feed, yeah. Dr. Jagdeep M. Kakadia's presentation, please.
It's showing Dr. Rakesh Shakya as president. So you present it first.
So we have some technical glitch. So I request our rocket surgeon, Dr. Rakesh Shakya, and he will be speaking on my innovative ways of premium IOL implantation in the very art of MSICS in the premium IOL implantation. And kindly finish in 9 minutes, please.
Okay. So, thank you, sir, for the kind of. So, good morning to respected chairperson. My topic is actually premium oil in the M6. So, M6, as you all know, nowadays is not an inferior surgery. So, actually it is due to the rising the patient expectation, spectacle independence demands, and premium oil penetration, increasing the India and cost contents also. So the premium outcome are not actually exclusive to the FACO. So as you all know, these are the all toric oil, multifocal or trifocal or EDOF lens and aspheric. These all are the premium oil. But actually for the patient, every oil is the premium oil. So as you, this is the myth, the M6 cause the unpredictable astigmatism and large incision at the poor effective accuracy, and premium oil actually the unsuitable for the M6, and surgical astigmatism is slightly higher. The proper actually, so the reality is that if you make a very proper tunnel, so the SIA is actually less than 7.5 diopter. So the vector planning is possible and the capsule stability is achievable, and excellent centration is possible. So the idea actually, what the ideal indication is that you can do the all type of the cases in this SICS. If there any case of the like dense cataract, small people and cost factory but demanding patient, and the rural setup and hard nuclei. So I'm actually working in the Chitrakoot, the Sadhguru Nature Kisala, in a very high volume center. So why this reason? Actually, the SICS is the it is also one surgery in the maximum patient, like 60% patient are the SICS, and the 40% we do the phaco. And every year actually we did actually more than 1 lakh surgery in our setup. So but actually if you implant the very premium oil, in the cases of the very hard category or jonule, maximum the big jonule we can't actually do. So the workup is the optical biometry and the manual keratometry and topographic is very important. Ocular surface optimization and pupil dynamics and ocular OCT also done. And astigmatism actually did with the rule or without with the rule or against the rule, and the pre-exciting corneal astigmatism, and decide the incision site strategically. So the incision planning and the location actually determine the SI vector, superior versus temporal. When we see the superior with the rule astigmatism, and according to the steepest axis. So we can actually control the SIA. You can make a small external width incision. It's about the 4 to 6 mm, and proper architecture, avoid the premature entry and avoid the buttonholing also. So the technique is the suitable for the premium oil is actually you can do the, it is depend upon the surgeon to surgeon is vary. Because actually when we see and the axis should be actually 5.5 mm, and optic capture it is overlap the optic all 360. So when we see and when we actually bone sealing is very important in the when you do the in any SICS cases. So now when we see that this is actually article, the customized incision cataract surgery, it is actually done actually published by the Dr. Boramani. Actually he's the give the another term is the customized incision cataract surgery. Actually shifting the focus from the surgically induced astigmatism to the surgically corrected astigmatism. And they give the actually idea like this is the ready retina type. This is the figure actually is the ready retina. If the astigmatism slightly higher like 1.25 or to 1.5 diopter, at more than you can make a slightly bigger incision like 7 mm. And then according to the diopter you can make an incision. Another thing the smart SI says it is also established in the things. And another actually another technique is the 2 mm incision, 2 mm small incision SICS also actually give the better result, and it is done by the Amul Sai. This is the mainly focus on the architecture of the tunnel. So actually the premium oil implantation actually the demonstrated by the Dr. Rajendra Prasad. So I am actually just showing the video. This is the unedited video, my unedited video. So for me, all cases and all actually all oil are the premium oil. So the surgery should be premium. Please give the volume, please. It's okay. So this is the unedited surgery actually I done in the 2 minutes. So this is actually when we put the MICS actually after making the side port, you can put the disco and fill the chamber and make a incision which is about the 5 to 6 mm, the conjunctival incision, and then make actually the 5 to 6 mm tunnel. This is the 5 mm tunnel, and then make a back cut. It is the side pocket. And then AC entry is done with the help of the keratome, and then cut up to according to the hardness of the nucleus. And then make a rexis slightly bigger. It is it is slightly 5.5 mm and more. And the hydro explantation of the collapse the nucleus and deliver the nucleus with the help of the wire vectors. and the removal of the cortical matter thoroughly, and also actually with the help of the Simcoe you can also polish the PC and even the margin of the rexes. And then put the oil in the hydro, put the Simcoe in the side port, and then leading haptic in the bag, and then dial the haptic with the head of the Simcoe. So actually this surgery actually completed less than 2 minutes, and you can see the rexus margin just opposite the all optic. And this is another case is actually we can do. This is the another case actually phaco is not actually much actually less actually give the not better result. So by this reason actually after that making the side port we actually put use the same technique. If you actually do the SICS in this type of the cases, slightly you can give the slightly more time actually, but this surgery also finished in the 2 minutes. So you can see the incision actually, this is the very frown shape, and then back the back cut. And after that we can entry with the done with the keratome. And initial, this is the actually the initial this patient was the phacolytic glaucoma. So after controlling the IOP, I actually take the surgery. So with the incision anterior puncture done with the help of any cystitum or as well as the atrata forceps. And then you can make a rexis, go very gently and then finish it. And then make a circular after making the, actually there is no need of the hydro in this type of cases, put the visco and deliver the nucleus with the help of the virovectis. So this the bacteria is the irrigating bacteria. So in this type of cases you can put the more visco over the nucleus and also behind the nucleus. So the journal, actually journal in this type of the cases, journal is slightly weaker. And the cortex actually very actually adhere to the capsule, so you could require the slightly more time to actually polish it. And then put the oil in the bag. Sometimes the cortex become calcified, actually not to remove it. But the central part is very clear. Slide is not. So actually for me, every case is for the, actually every aisle is the premium aisle, or surgery should be premium. So thank you for the kind of attention.
Any question from the audience? Okay, so we will move on to the next talk by Professor Manisha Rathi from RIO PGI Rohtak, and she will be speaking on role of counseling in the modern era. Listen more to get the most happiest of the patients.
Good morning. I'm just checking the time. It's not afternoon yet. Good morning. Thank you so much for being here and for locating Trade Room 4. It was a little difficult to come to this place, but it's a wonderful morning. Really grateful to AIOC and really grateful to Professor Arvind Moria for this opportunity. And I'm really humbled to be sharing the stage with Dr. Kakadia sir, Dr. Gopal sir, Dr. Rajendra Prasad and Dr. Arvind Moria. Thank you so much. So now my role, he's given me a new topic. So I also read up and I was really happy to have this experience to read up about it. Counseling, listening, it's a two-way street. When you counsel a patient while they're loading, I'll just talk a little bit about it. So when you are counseling, you are listening, you are asking for doubts, you're clearing their doubts so that you do not get unhappy patients. If you do not have unhappy patients, you'll have happy doctors. Happy doctor, happy patient to prevent litigation, financial loss, stress. We all talk about de-stressing, so that is one of the important ways to do that. we have the art of listening is really important. You all are exhibiting the beautiful art of listening where you're not looking at your phones, where you are seriously trying to see what the speaker is saying, and I should also be in tune to what you are listening to, and in between if you get bored, I should put in some snippet about a movie or something funny so that I can maintain your interest. My presentation, please. That's it. Okay.
This side.
Thank you. So, first presentation.
So how many of you implanting premium IOLs along with the M6? Anyone? Sir, your experience kindly, 1 minute. Yeah.
Sir, I am primarily a phacosurgeon, but primarily a premium IOL surgeon.
Thank you.
Our myself and Dr. Asisha's multifocal or progressive progressive IOL practice is more than 70%. We discourage the patients to go for a monofocal IOL. Always we encourage them to go for either EDOF or multifocal.
Thank you, sir.
Thank you.
Yeah. Professor Manisha Rathi.
Thank you so much. So Dr. Moria has given this topic. He always gives us unusual topics and interesting ones which are very important today. Role of counseling in the modern era. Listen more to get happiest patients. We have 2 ears and 1 mouth. Always remember when you are listening to a patient. Why is counseling crucial? Because it reduces patients' fear, apprehensions, gives them more knowledge, allows them to interact, allows them to choose the goal along with the surgeon. You can have handwritten notes, educational videos, or most important I feel is verbal conversation with the patient before the surgery. What is counseling? Words of comfort, skillfully administered, oldest therapy known to man. And in any surgery, the counseling will involve informed consent. An informed consent is taken only after the patient knows about the nature of the treatment, the alternatives available, the pros and cons of those treatments, risks, benefits, and opportunity for questions. One very important thing which may not be mentioned is financial burden on the patient and affordability of the patient. So if they are a little embarrassed to tell you what their budget is, tell them very clearly. Give them different options. Do not force one choice upon them which you think may be the best or the premium IOL of your choice. Give them the pros and cons, let them decide. Listen and understand. There is an art of listening. What is the importance of listening to a patient? Increase trust and rapport with the patient. Enhance diagnostic accuracy if you listen. They may give you a history of an attack of uveitis or a family history of some disease which you may not be aware of. Improved adherence to the treatment when they trust you. Greater patient satisfaction, and it also provides emotional support if they feel they are being heard. So what is the best way to listen? Avoid interruptions. Active listening. Nodding, use body language like ma'am is doing right now, nodding, eye contact, and open body language. Of course, open-ended questions. So you say, do you want to ask me anything? Do you have any doubts? They'll talk about some person they knew who had a particular IOL surgery and could not see after that and what happened in that patient. So answer those doubts patiently. The ORS method, open-ended questions, affirming, reflecting, and summarizing. Then you pause, be silent. Let them ask you whatever they want to. So this is, according to studies, 1 of every 6 patients is considered difficult or a complaining type of patient. So how do you avoid unhappy patients? Prevent unhappiness. Prevention is the best form of cure because the patient has so much overload of information. So be on the same boat, have the same direction, the same destination for the patient and you. That can only happen with synchronization. If you pull the oars in different directions, the boat cannot move in the same direction. So before treatment, alignment goals. You have to talk, you both have to have the same goals, achievable goals. Do not promise them the moon and stars. No assumptions that the patient wants. Patient wants good vision. He does not bother about which machine you're using or that is the latest in India that you have. Seek and maintain an active dialogue before the surgery, just before you put them on the table, after the surgery, and in the follow-ups. Why would the patient be dissatisfied when we deal with them? Managing critical, difficult, dissatisfied patient is now a critical skill with the online reviews and the social media presence. It would destroy your years of practice and experience. So what are the patient factors? Unrealistic expectations. Why would it be unrealistic? Because the surgeon may have had a hoarding or an advertisement to give them those expectations. Ignoring medical advice. So when you talk to them, they're less likely to do this. Dissatisfaction with your care without personal involvement, persistent complaints, insistence of different drugs being prescribed. They want more drugs sometimes. Verbally abusive. You cannot reply in the same coin. You have more to lose. The patient has already lost something. They will not complain without cause. So sometimes it can be that the cause is very small and they complain this much. Or sometimes the cause is this much, they may not complain and just ask you for advice. So are we promising them the moon? Are we showing them expectation which is not real or not achievable versus the reality? Prevention is better than cure. Prevent unhappiness. And how do we do that? Informed consent. It's actually informed. When you give them information, but you let them ask what their doubts are on that information. So inadequate, they studied a case series of litigations. Inadequate or imperfect informed consent was the leading cause for litigation. And what is a valid consent? I would go to the last point. Enough information about options, benefits, risks, when they can raise concern and ask questions. Then of course legal capacity and give the consent voluntarily and consent for that particular treatment. If you take them for surgery and you have a nucleus drop and the VR surgery is done, explain the whole procedure. You've taken consent for one surgery, it can cause problems later. Anesthesia. People nowadays don't want a block, but if I'm going to do a glaucoma and cataract surgery, I am going to give a block, so I have to explain to the patient, trust me, they will say yes, please give me a block if that is the surgery you're planning. What are the pros and cons? What are the dangers? And what should they expect? How long will the effect last? What should they not do? Surgical procedure, options, all the options available, all the price ranges available, which we don't write about. Pros and cons, ups and downs, type of IOL, type of options, which is more suitable for that eye. Pros and cons based on that. Insurance cover, money, money, money. We cannot ignore this. How much money will they be reimbursed for? Will it be cashless? Will they get the money later? When will they get it? What is the procedure you're using? What are the options for procedures? What is the cost of IOL per surgery and how much is out of pocket for them? Non-surgery related information. Will you need an attendant to come? What time will you come? When will you eat? Controlling systemic diseases. Do you have to take the medication in the morning? Hair wash, clothes, ornaments. If you ask the patient to take off ornaments just pre-op, they are very apprehensive and they are stressful. So avoid that. Tell them beforehand. Risk of the surgery depending on what their pre-op condition is, which procedure, which risk, vision, expectation. So you have to manage the expectation of the patient and your own expectations. Reality has to meet expectations. Listen to the patient. Avoid them, any unhappiness. Education should be full and do not be afraid to tell them of the various things that can happen. Now this is a patient of pseudo-exfoliation. There are potential problems which can occur or difficulties during this. So what are the pre-existing ocular systemic diseases? In certain studies have found that the number one cause of post-operative unhappy cataract patients is residual astigmatism and dry eye disease, which sometimes you don't think of. And of course the patient not seeing them. In a very good center, a patient who's a relative of mine, it suited them, the location. And they said that you said, okay, this person is good and fine, the surgery is very nice, but the doctor has not spoken to me. Post-op came and looked at my eye and just went off. I tried to ask a question and the junior was answering. So I want the surgeon to talk to me. This is a genuine problem. So what are the other predisposing factors? Retinal diseases, glaucoma, adnexa. In all the retinal conditions, a lot of people recommend now
Yeah,
OCT of
one
the
more
macula.
minute, please. Yeah.
That's all. I'm done. Then accurate IOL calculation and about the premium IOLs, I think they'll be telling you. See, you can't say a patient is just complaining. They may be genuine visual disturbances. Always consider the patient to be genuine first of all. So what can you do for them? IOL exchange is the last option. In multifocal IOLs, the PC wrinkling can cause slight shift and the multifocal IOL is very sensitive to that. So you have to listen to the patient. Just as you're beautifully listening now, time may heal. Sometimes neural adaptation may take 3 to 6 months. And you have to turn that frown upside down. It has to become a smile. And this is a camp which last week I went to a camp and you can see there were 335 patients. we are listening to them, first in a group and when they come to us. And then we give a slip with the name and number, come to the medical college. You'll be surprised throughout the year till the next camp. I get patients for cataract, glaucoma, screening, and I'm very grateful to them and very grateful to all of you here. Thank you so much.
Thank you, Professor Manisha. Now over to our next speaker.
Thank you, Dr. Moria, and good noon to everybody. Good noon to the dignitaries and luminaries on the dais. I will straight away go on for my presentation. Friends and colleagues, today we are very happy to introduce to you OmniGlow, which is a stereo coaxial illumination device having its own dual lights which can be fitted at the bottom of any surgical microscope, which will convert it into a Lumira eye-like stereo coaxial illumination. It is quick and easy to attach and detach OmniGlow, and when fixed with a single bolt, it becomes integral part of the microscope. And OmniGlow is now complemented with VideoGlow, which is just a 50 grams matchbox sized micro head full HD video camera which is inserted directly into the beam splitter. With OmniGlow, omnipresent, homogeneous and full red reflex for each eye of the surgeon with greatly enhanced stereopsis is 100% guaranteed in any position or any tilt of the eyeball. With OmniGlow, we never need blue dye for capsular axis except for white mature cataracts. Not only we can see, but we can also record with VideoGlow what the surgeon sees in exact and in vivid and beautiful colors. In hydro procedures, the fluid wave and the golden ring reflex can be seen as well as recorded so beautifully well. Red glow is omnipresent even during the phaco-fragmentation procedures. OmniGlow also has enhanced stereopsis optics. Please notice that even in this 2D video, we can fairly well perceive the depth, the enhanced third dimension. Thanks to the optical phase contrast of OmniGlow, we can visualize every optical interface so well that surgery becomes a real pleasure. OmniGlow not only enhances glow, depth and contrast, it also enhances surgeons' confidence and morale to handle tough cases. During the bimanual IA, please notice the amazing clarity of BSS versus visco interface, of cortical sheets, fibers and fibrils. Anterivitreous up to mid can also be seen so well. And also please notice the clarity of the diamond dusted tip of IA handpieces. Cortical fibers and fibrils can be so beautifully seen. During the removal of cortical fibrils and vacuum polishing of the posterior capsule, the star folds of the PC are so well visible, so well in time, that the incidence of PC rent after having OmniGlow is almost nil. Polishing of the intercapsular rim with Nightingale polisher is not only so beautifully visible, but is also so very well recordable. OmniGlow ensures full red glow even in small pupil, in any tilt of eyeball, in any position. OmniGlow name is derived from the fact that it gives omnipresent red glow which the conventional illumination of normal or basic microscopes cannot give. Even in 2 mm pupil, the glow is faithfully and always there. Even in a nearly mature full cataract, we can still see some glow with OmniGlow. Before the IOL implantation, when the eye is aphakic, we can see on screen the posterior pole, the disc, macula and the retinal vessels on table without any additional optics or lenses. thanks to the superb glow, excellent contrast and enhanced stereopsis, all due to the phase contrast stereocoaxial optics of OmniGlow. We can do axis modification or enlargement for matching the axis border to the IOL's border so easily and so confidently. Thus, OmniGlow gives us the additional power, proficiency and finesse of doing femtolaser light accurately sized and well-centered re-CCC.
Amazing clarity है, Lumira से better. नहीं नहीं नहीं.
With few RBC clumps ingressed in the anterior chamber, aqueous humor's natural current can be so beautifully seen and recorded. More than 5,000 surgeons are using OmniGlow in more than 75 countries of the world, and there some common happy feedbacks are: thanks to phase contrast, ingress and egress of surface fluid and blood cells with high movement and cardiac rhythm can be seen and recorded so well. In a well-dilated pupil, we can see zonules so beautifully well. Visco wash is not only clearly visible, it is so beautifully recordable, washing out debris in front as well as from behind the IOL. The combination of OmniGlow and VideoGlow gives nice smileys, not only on patient's eyes and face, but also on surgeons and entire staff's face. In this case of a PSC cataract with Fuchs dystrophy, thanks to excellent glow and the enhanced stereopsis by OmniGlow, we could safely complete the surgery without any additional damage to or loss of endothelial cells. OmniGlow is also very useful for medical retina practice. We can beautifully see the Zumab drug going into the vitreous, and thanks to the excellent glow, even in small pupil and greatly enhanced stereopsis, we can always avoid injury to posterior capsule in phakic as well as pseudophakic eyes. OmniGlow is a light in itself, dual lights in fact, so it becomes the primary light source. Microscope's own fiber optic or LED light becomes secondary or not at all necessary. OmniGlow dual lights are non-fusible halo LED, that is halogen spectrum light emitting diodes. OmniGlow lights have very long life, more than 35,000 working hours. At the rate of 20 minutes per surgery, they will last for more than 100,000 surgeries. That is almost whole professional life of a solo private practice surgeon. OmniGlow can be made and be fitted for any make and model of surgical microscope. It is specifically made according to the size, shape and optical beam path of each model of each make. OmniGlow, just at the fraction of the cost, can rejuvenate and convert your old microscope into a Lumira 700 or Leica M822 like microscope. OmniGlow is not just the glow, it is glow plus enhanced stereopsis and excellent contrast. Duplicates of OmniGlow do not have this much clarity, stereopsis or contrast. Please notice this is a persistent hyaloid artery with stagnant RBCs in it in a posterior polar cataract case. The Space Tech, ISRO and NASA level optics of OmniGlow and VideoGlow record the capillary blood flow, the RBC clumps and plasma flowing in corneal venous vessels like a walking line of ants or like a river flowing on the Mars. According to Dr. Satish Sheth, OmniGlow is actually OmniGold, and in words of Dr. R.C. Shah, it is Oak Money Glow. Thanks to them for these nice and kind words. And in words of Dr. Arvind Kumar Maurya, it is OmniGlow, a golden glowing Om with solar glow. By the way, Om is the Navinad of the sun. Thank you very much for your kind attention and patient listening. Thank you. Hello dear friends and colleagues. Today we are very happy to introduce
One quick question. By the time our indigenous terminator is preparing for his talk, so what is the combined cost of this OmniGlow and VideoGlow, sir?
So OmniGlow is 2,35,000 plus GST. And VideoGlow has two models. One is only for the anterior segment surgeries, that is 1.25 lakhs plus GST. And other is VideoGlow RC, that can record the retinal surgery as well as the anterior segment surgery, and that is 2.25 lakhs plus GST.
So almost 5 lakh we can have the combined both the things.
Yeah, around 5 lakhs.
Yeah. Thank you. Excellent innovation. Yeah.
Thank you.
Yeah. Now I request Dr. Rajendra Prasad sir.
Good afternoon, and thank you, Professor Maurya, for giving this opportunity to be here in this wonderful IC with eminent speakers. So I'm going to talk about premium IOL implantation in different situations. As you know that achieving emmetropia or perfect vision without glasses is a common goal in modern cataract surgery. Implantation of these premium IOLs have become a new normal now. You come to the clinic and see almost 70 to 80% of the patients have started asking for the vision without glasses after the cataract surgery. You have different types of the premium IOL in today's cataract market, you all know, to address the options of presbyopia correction at the time of cataract surgery. And we can definitely provide a reasonable expectations to these patients with the technological advancement in modern presbyopia correcting IOL, high precision diagnostic tools, and we have these accurate IOL power calculation formulas and devices now these days. And advanced visualization system, as Dr. Kakadia has just shown, a beautiful OmniGlow. So I will definitely take this device in my microscope now. And specialized phaco systems also we have now, and intraoperative essential manual tools so we all have been using in our cataract surgery, and to give the perfect result to the patient. So surgical technique is very important because you have all these tools, but then how you operate your cases is really important. So you have to have a perfect surgery for these premium IOLs. You do not want any kind of complication. Even in this particular case, as you can see here, this is a posterior polar cataract. I have planned for the premium IOL for this particular patient after explanation and complete counseling, as Dr. Manisha has given the complete thorough advice how to counsel the patients for these premium IOLs. So a good Raxis, a perfect Raxis of 5.5 millimeter has to be there in these cases, not more than that, not less than that, because to function the premium IOL you have to have a perfect Raxis, a good hydrodissection before the extraction of the cataract. But in a posterior polar cataract, never do cortical cleaving hydrodissection. You have to do a multi-quadrant hydrodissection. The wave should not go behind the capsule. It should stay in the equator only. And then after completion of the cleaning of the anterior part of the lens, we normally do this technique, stop and chop in posterior polar cataract. Never do chopping, never do any other technique. This is the best technique. Segment and then flip out one of the segment out of the capsular bag, emulsify on the capsule, not deep into the capsule, because the posterior capsule is very weak in these cases, and always fill up the chamber. Don't leave the chamber unfilled, because the posterior capsule may rupture, may disrupt any time. So you have to take all care, remove all the cortex. You have to see that posterior capsule is clear or not, because the posterior capsular polishing is going to be difficult in the posterior polar cataract, but still I am doing here to clean up any fibers left. And this is the trifocal IOL which I am going to implant in this particular case. The centration of the IOL, the positioning of the IOL is very important. The cleaning of the viscoelastic from back of the IOL is another important point. And don't handle too much. And once you have a IOL centered, look at these reflexes on the anterior surface of the lens. Your lens has to center in the center, and to remove complete viscoelastic from the capsular bag. So this is how you can have a good result in these cases. And the astigmatism is another important point in these premium IL. You have to correct 0.75 diopter of the astigmatism. Don't leave less than this, more than this of any astigmatism in the eye. And the top formulas which you can use for the astigmatism, the Barrett's True K formula is very good. It gives you a perfect result. There are other formulas also for this, for the situation. And then again, the surgical technique of these toric premium IL is another important point. You have to have a perfect marking of the toric axis. You can use any of these tools. I normally use bubble marker, which gives you a perfect result. You can have these high-end devices. If you don't have, you just use the bubble marker. It gives you a good result. Your incision is very important. Make always the hydro seal with triplanar kind of incision. About the capsular axis has to be perfect. It should not be more than 5.5 mm. Optic of the eye by the capsular edge, and do a very, you don't have trouble in removing the cortex and the epinucleus during the surgery. Always rotate the nucleus. And then emulsify the nucleus. So I'm showing the chopping of the little harder cataract, the chop which has to go through and through, and then pick up these pieces. And you can simply emulsify, and once after the emulsification of the cataract, and to do a good capsular polishing. This point has to be stressed. Good capsular polishing. Don't leave any kind of fibers on the capsule, because if these premium IL patients develop the capsular fibrosis or the posterior capsular opacity, then it becomes very difficult, because although we have IAOC capsulotomy, but the results are not that good then. So you have to make sure that now this is the toric IL which is being implanted, and the positioning of the toricity and this axis has to be, and as you can see here, because this is the plate haptic IL, so you don't have much problem. You can move it right and left, unlike these C-loop haptics. So once you have done the implantation of the IL, then remove the viscoelastic and seal the wound perfectly. Another case is the intumescent white cataract, which Dr. Moria had asked me to show the premium IL implantation in intumescent white cataract. This is a intumescent white cataract, fully mature, very hard nucleus, this patient. And again, the incisions are very important, because make incisions so that you do not induce any astigmatism, additional astigmatism into the wound. And capsular axis. Always stain these cataract with the methylene blue, and make sure that your capsular size goes 5 to 5.5 millimeter. And once you have done the capsular axis, I'll just fast forward this video. So they chop the nucleus, so because the nucleus was very hard. Always fill up the anterior chamber with the viscoelastic. Don't leave the chamber empty, so that your cornea is shaped. Complete the removal of the emulsify the nucleus. Do a good polishing, and then this is again a trifocal IL which is going inside, and you have to make sure that the lens is well centered and your wounds are well sealed. So, although we have these different types of premium IL, premium ILs, but we still don't have a perfect presbyopia correcting IL which would provide you a full range of vision with minimal to no dysphotopsia, without distance contrast loss, without intermediate or near vision loss. So in this situation, what we do a mixing and matching. So mixing and matching is one of the process which we can apply in these premium IL implantation. You can implant one IOL so that to cover up the drawbacks of the another ion. So here I'm putting a trifocal eye in one eye and the refractive EDOF eye in the another eye. So you get a very good result in these cases. So success depends on patient selection, biometry prediction, corneal astigmatism correction, surgical technique, and intraocular lens choice is very important. So you have to do a very good preoperative workup is very important, and while choosing the eye, will keep in mind the visual needs of the patient, the lifestyle of the patient, ocular health, and as Dr. Manisha said, the budget is very important. Don't push these premium IL for each and every patient so that patient is unhappy after the surgery. If the patient agrees for this, you have to do a good counseling before you select or plan for the premium IL. Thank you very much.
Thank you, sir. Now I would like to call Professor Arvind Kumar Maurya, and he is the renowned professor, renowned surgeon from the Hyderabad, or it is a clinician and innovator. So as you all know and all know.
Thank you so very much, Dr. Rakesh Shakya. So a very warm good afternoon, all of you. And so my this course is on how to develop this economical subspecialty clinic of amblyopia to make more money. Its slides are not moving. Yeah. So the background as vision is far more than the Snellen and the Logmer. It is the eye-brain ability to process the motion. It is also about the hyperacuity. It is also about the contour integration as well as the shape perception. And in India, 4% of they are suffering from this amblyopia. And earlier the onset, the greater is the deficit. And the adult refractive amblyopia are regarded as associated with plasticity and rigidity. And this is the untreated group. This we need to target. How to do it? Let's see. So the roadmap is the innovation, and it needs to be cost effective also. So the subspecialty clinic for the lazy eye requires a blend of a specialized high volume care for children. It needs to be innovative, cash pay options for the adults, capitalizing on the rising demand for both pediatric screening as well as the amalgamation of the new vision technology by integrating advanced digital therapeutics with efficient operational management, and this specialized clinic can significantly boost revenue. So there is high ROI therapeutic offering and revenue drivers. So these are digital therapeutics, which are the FDA cleared digital therapies like the Revital Vision, and these are cash pay or subscription based, offering higher margin, active vision therapy or orthoptech, and a specialized diagnostic like the cutting edge equipment, AI driven screening tool, Scan yet to come in India, but it's under FDA, so very soon it will come in India. Then the atropine penalization or the advanced lenses, which are the high quality lens options, and the adult amblyopia treatment using the specialized non-invasive digital treatment, because these are the underserved and often cash pay market, which is wide open. This we can target. A strategic operation and efficiencies of pediatric friendly environment, orthoptist utilization, telehealth integration, and a streamlined scheduling, and marketing and referral network. So pediatrician outreach as a primary referral center for the local pediatrician as well as the school nurses, and digital presence all over the places with a strong online presence focusing on early detection and modern non-patching treatment to attract the parents who are searching online for the treatment of amblyopia. And billing and reimbursement optimization. So there is this innovation by Dr. Santanas Gopal. So we are the first who have done the clinical trial, the ICMR registered with 493 patients till now. So this works on the top-down impulses, and the covert attention and the overt attention, they stimulate the lateral occipital cortex via the top-down impulses, and these are the motor and sensory aspects of vision which are used for the development of orthoptic magnocellular stimulator. So we just need these things, logmar, the palliropsin as well as the red dot stereo acuity chart. So there is sudden appearance of light that stimulate the saccadic movement in association with the stimulation of the fovea in the V1. So there is suppression of the retinal area between the fovea as well as the peripherally stimulated retinal point, and there is repeated stimulation of the magnocellular cells that leads to stimulation of fovea, and these prosaccade, they are associated with maximal stimulation on the V1 area. So let's see how it is done. So patient needs to sit with best corrected visual, the improvement, 1 meter distance, and follow these light, the central green and the peripheral red, who are coming within a span of 140 to 145 millisecond, and it's a half an hour therapy. So let's see, 65-year-old gentleman, right eye 24.5 diopter, left eye 19 diopter. We did phaco in this, so these were, left eye was 6/6, contrast was reduced as well as stereo was reduced significantly. So after 3 weeks of this orthoptic therapy, the patient improved to 6/6 part. So who is saying that the plasticity and rigidity is there in the anisometropic adult refractive amblyopia? And we have treated so many patients, 40 plus such patient. Contrast improved from 0.35 to 1.35. And contrast even improved before the visual acuity. This is what we have observed. And stereo acuity come to normal, more than 800 second of arc to 70 second of arc. And patient was so happy, and it's just also our team was so boosted with this clinical trial. So there is a role of functional blood oxygen level dependent MRI also, because in the amblyopia patient it is reduced substantially in the occipital frontal and the parietal lobe, and there are significant changes in the post and pre-treatment. Other indications, 6 nerve palsy, partial third nerve palsy, Alzheimer, hyperactive children, attention deficit disorder, early recovery, and patient needs to carry only a laser torch. And we have observed that it is the fastest recovery time as compared to the other treatment modality available in India for the management of amblyopia. Add-on services, so in-house optical shop. In summary, the table of revenue opportunities, so service component and the potential revenue stream, so comprehensive examination along with the insurance and medical billing friendly, digital therapy, because patching is no more in vogue, and this in-office orthoptic we need to have, and the pediatric optical that we need to work on, and it gives significant revenue. So thank you and welcome to Jaipur. Do visit all the places. Thank you so very much. So we have time, so I'm happy to take any question. Even the innovator is here, so we can answer. And its cost is 1.4 lakh plus GST.
About 1.5 lakhs.
Okay.
At the moment it's 1.5 lakhs with no GST, but I am planning to sell it off to somebody, company. Then it will go to 2.5 lakhs plus GST. Now it is 1.5. And now it's time to buy. It's available in Akriti ophthalmic products in P206. If you go there, I will come when you have given time. I'll show you how easy it is to use and fix it up.
Mike, sir.
So, sir, for the orthoptic, the patient has to come to the clinic every day?
Right now, the patient has to come to the clinic for 15 days minimum.
Right.
Younger patients like children less than 10 years, they need to come only for 10 days or even 7 days.
Okay.
Older patients need to come more. The adults need to come for longer period. I'm trying to develop a program where we will give them the video on this thing, pen drive, which they can fix to the TV, and do the same exercise at home.
At home.
But that's taking time. That software is costing us too much.
Okay.
But once we do that, probably we'll give, along with the machine, we give the video to do it at home.
Right. So can it be, instead of a machine, can it be just the software that the patient can take home and...
No, once you understand the whole machine, you will understand why it has to be like that. Because the time difference between one peripheral and central retinal stimulation should not be more than 200 milliseconds.
Right.
If it is more than 200 milliseconds, it's of no use. It should be less than 200 milliseconds. And if it is less than 200 milliseconds, what happens is the top-down impulses, they stimulate the fast forwarding of the bottom-up impulses. That is, the impulses coming from retina to the cortex. And that can happen only when there is a coincidence of the two central and peripheral receptors.
So those lights are lasers or they are just simple LEDs in the device?
We can discuss later
So
on
we'll
after
discuss it
finishing.
later.
Yeah, yeah.
Thank you,
Yeah.
Dr. Arvind, for the wonderful presentation, and we'll invite now Dr. Santan Gopal. Dr. Santan is going to talk on when the investment is huge, practice is the best choice. Dr. Santan Gopal is a very prominent surgeon in South, and he has been my senior at RP Center, AIMS, Delhi, and a very close friend and very gentle person, and very innovative. Like you have seen, like this machine he has devised and for the treatment of myopia, and it's really effective and it gives a very perfect and fruitful results. So Dr. Santan now here.
Yeah. See, I started my ophthalmic practice. I have no slides. I have just my experience to share with you, and those of you who are youngsters who are wanting to start the practice or who are into early practice can gather more information and take it home and apply. I started my practice with just torchlight, my ophthalmic career with torchlight and some loop. From there, then I went to RP Center, and I was flabbergasted at the number of instruments they had in RP Center for ophthalmology. So I was surprised, but I learnt a lot. But when I left the ophthalmic center, RP Center, I had again nothing to practice except torchlight and loop, because the initial cost of setting up the place is phenomenal. It was then more, but it is now is astronomical. You need at least, to average practice to start, you need 1 crore apart from the place. So if you have only one person and he is capable of spending 1 crore, it's okay. But if you have 2, 3, 4, 5 people, and all of you have together cannot spend that 1 crore to start the practice, then you need only 25 lakhs per person. Then you get access to 1 crore worth of instruments. Or now we have about 18 people. We have more than 10 crore worth of instrument access to all of us. And we have not spent money individually in any of these instruments. We have collectively spent money, but in return we have earned more money than what we have spent. Started with 3 important findings. 1, you must have in the group the members who can understand you and who are cooperative all the time. Because you need at least the practice to survive for 3 years. If the practice survives for 1,000 days, it will survive for a long time. So ours is the only group practice which has survived more than 25 years with around 18 people in LASIK practice. We started as a LASIK refractive center. Now we offer many different services, but we do the most ethical practice. The only problem is that we need to spend time. Each of us take time out of practice, out of family, and spend center. It's a neutral center. It belongs to everybody, but it belongs to nobody either. It belongs to everybody because you can say that you are a part of it. It belongs to nobody because you don't own any part of it. You own only a little bit of it, not every bit of it. So its advantages and disadvantages. The advantage is that many people from outside can refer you lot of cases because it doesn't belong to one individual. So say go to LASIK center, get the fields done, get the OCT done, get this test done. That earns us money. The investigations themselves earn about 50% of our income. Whatever we spend on the center, 50% of it is covered by the investigations. The remaining 50% comes from doing the LASIK and other things. So you may have access on your own to a few instruments, but you are unlikely to have access to all the instruments. The most important point that you have access to is brains of 18 people. The brains of 18 people you won't get by paying any money, because each individual can think and act and tell you this is a better way. To give you a small example, we were getting LASIK flaps of about 140, 130 microns. So we all sat one evening and we opened the whole machine, the microkeratome, and we looked at it and decided what should be done to get thinner flap. Then we realized that it is possible with our machine and with our microkeratome to get flaps as thin as 100 microns. But there is a special technique of placing the microkeratome on the eye and special technique of not applying pressure on the eye and doing it slowly for the vacuum to build up. With that technique, we were getting about 100 microns of flap for LASIK, which is what you get with even laser machines, correct? So by putting 18 brains together, we were able to come out with thin flaps. Even before they found out with other lasers, excimer lasers, that they can get thin flaps. We already had got thin flaps. That's one. One of the drawbacks of the group practice is you have to be ethical, 100% ethical, number one. And number two, the financial thing has to be very transparent. If the financial thing is very transparent, you end up paying tax. There's nothing you can do, you end up paying tax. So to avoid paying tax, what we do is buy more instruments. You buy more instruments, you get more money, for which you again pay more tax. So to avoid that, you buy some more instruments. So it is a vicious cycle. So when you buy more instruments, you get more money, and you don't want to pay more tax, you buy more instruments. Thereby, you expand. So when you start, you need to find 5 or 6 people in the group who have similar passion towards developing the center. They may not have money, but they have phenomenal amount of interest and passion towards developing the place. So of all the centers that have developed all over India, we are the only center who have survived 25 years. And we are still growing because our next generation is already trained and they are in line. About 5 ophthalmologists have their children already trained as ophthalmologists. My daughter is not a doctor at all. But still I get money from the center because it's a group practice. Whatever money is there, they will distribute to all equally. Some may work more, some may work less. Do not compare yourself to others. Money is getting more money. He's doing more cases, he gets more money. So be happy with what you get. Group practice is the only way forwards with the cost escalating phenomenally these days. When you're finished, during the time you finish, you identify 5 people. A good administrator. A good administrator is one who administers but who is not liked by any employers, who is not liked by any employees there. A good administrator, he is a good administrator.
Please, time is over. Please conclude, sir.
1 minute?
Yes, sir.
Okay. LP Agarwal is a wonderful administrator. you may not have heard of him, but nobody liked him. He built a ophthalmology department from 2-bed to what it is today, 1,000 beds in RP Center. That can only a good administrator do. Then you select other people doing retina, very essential, doing squint, very essential, doing LASIK. All of you can do LASIK. So group practice is the only way forward, with insurance also asking you to do a lot of things. Thank you very much.
Thank you very much for the nice instructions and the advice to the young ophthalmologist. And now we'll have a group photograph.